I was mentioning earlier this morning that it's a struggle to keep up with a presentation that is new every year, because I got so many times asked to talk about this topic that I'm afraid that I'm repeating myself. So maybe next year we're going to change it a little bit. But definitely, as Gerl was saying, we spent a huge amount of time trying to understand how we could improve flexible endoscopy and take it to the next level. Nothing to disclose. My presentation is going to really focus on therapeutic endoscopy because I'm a firm believer that tube-based diagnostic endoscopy is going to die, and we have a lot of very nice and constantly upgrading systems that are capsule-based. And yes, today mainly those are for purely diagnostic, but I'm pretty sure that in the near future they will be capable also of taking biopsy and delivering therapy. And also the way they are driven is going to be more and more precise. So you just have to think of the beautiful work done by Pietro Valdastri with his magnetically driven capsules. Who would like a tube to have a diagnostic procedure if you can just swallow a capsule? Let's be honest. So I'm sure that it's going to be patient-driven. And also we have the opportunity to add to that artificial intelligence in order to enhance dramatically the power of our naked eyes. Because to be honest, you can have a very expert endoscopist, but if you have somebody who's just starting to perform endoscopy and colonoscopy, very often you can miss lesions. And you know, a lesion could be a precancerous condition or cancer. So if we have an enhanced view and a better understanding of what we're looking at, using the latest technology such as endocytoscopy, as shown here, and an algorithm to analyze beyond the simple MBI or normal light vision, we can definitely take it to the next level. And this is very important because today it is getting more and more possible. And I think that we have to acknowledge the fact that computers are much better than us at understanding images, and their memory is superior, and their ability to detect and choose between two images to reduce the rate of missed lesions, but also to reduce the rate of an unnecessary polypectomy is really going to bring a tremendous impact to what we do every day. So we're going to focus on therapeutics, and basically today there's still two systems, master-slave-driven instruments and master-slave-driven endoscope and instruments. And why is that so important to us? Because a few years ago, now almost 15 years ago, we were really firm believers in the fact that we could change the way we practice intervention using flexible endoscopy. And it's really plausible if you think that in the past 20 years, flexible endoscopy went to a purely diagnostic tool, to interventional, to surgery delivery using flexible scopes. And we, and GERB too, were part of those surgeons and endoscopists who believed we could actually perform surgical procedure using the natural orifice. And we did that. I still don't understand how, using standard scope and standard instruments which were not meant nor designed to do so. And of course, it was very nice for the patients because they had no scar, no pain. It was a pain for the surgeons because ergonomically was not possible. And for the OR personnel, a simple case that would take 20 minutes of cholecystectomy became all of a sudden 4-hour procedures. And they were also concerned regarding the ergonomic of working. You see a very good friend of mine, Gianfranco Donatelli, who's crossing his hand around my neck, trying to help me or to strangle me. Definitely something that is not a comfortable working environment, or you really want to pick somebody you know very well and a friend to do so. We also had concern in terms of safety. This is our 11th case of transgastric cholecystectomy, and although we were pretty experienced surgeons and endoscopists, we were dissecting the CBD and we stopped just because of experience. So definitely this technology, as it was performed, was not meant to be widespread. And one of the past presidents of Smith, a very dear friend, Amir, who's going to come later today. So Amir Isolde is a surgeon entrepreneur, and age 50, I can't disclose his age because he's still really good-looking, handsome, and brilliant. He said, this is how I feel when I perform flexible endoscopy. So age 50, he decided to learn. It's like having tweeters stuck to my eyebrow and trying to do things that I am really not comfortable doing. And being a surgeon is so frustrating because you're used to triangulate and use your hands. So the idea was really to come on with a system that could bring surgery into the lumen of the gut, and also probably, in the end, a transluminal. So better instruments, better platform, more stability, more precision. And this is what we wanted in Strasbourg. We started 15 years ago to design this platform that's called the Anubiscope. It changed its name today, but it was a platform capable of triangulating with very sturdy 4mm instruments that could open up into the abdominal cavity. But still, it was pretty difficult to have the precision at the end effector going through a 110 centimeter system. So it was obvious to us that we had to improve it, and in order to do so, we had to add robotic driven control to the platform. And this is the new system that's called EASE, Endoscopic Assistance for Surgical Endoscopy, and is a master and slave remotely driven endoscope that is 53 centimeters in length and is mainly used today for colorectal and transoral ENT procedures. But as you can see here, it's really representing very well what we wish as a surgeon. We wish triangulation, we wish precision, we wish really to achieve the same location for our instruments and movements for our end effector that you have when you operate. And that is very important because if you have triangulation, if you have the right traction, even with a very simple monopolar cautery device that is about 2.3 millimeter, you can achieve a very fast, very precise, very performing dissection that is much, much easier than an ESD technique, which is actually extremely complex to perform. So it has the potential to democratize a technique that today is mastered in Asia, in a very few centers in Europe, but it's not there for all patients. And who would like to have a colon, piece of colon taken out, right or left colon, rectum taken out because of the inability of the endoscopist or the operator in general to remove a lesion that is superficial cancer and could be taken by endoscopic only if she or he had the skills? So this is the philosophy behind this platform that also has the ability to have as end effectors and instruments, the same instruments that you would use when you perform a surgical procedure. It also has the possibility to orient the whole system in relation to the position of the lesion, so that no matter if the lesion is anterior, lateral, posterior, you can turn the platform and you will be exactly operating as you wish, with control on the location of the instruments and the platform. This is very important because there is a screen that tells you exactly where you are, how your scope is shaped, so you never lose control of your field and of your tools and instruments, which is very important. But most importantly, when we ran a study trying to assess whether this was really useful, we found out it is extremely useful. And we were looking in particular at the learning curve, because we know that ESD is complex, and we know that it can take years for an operator, surgeon, or endoscopist, it doesn't matter, to learn the technique. And what we could see is that novice did perform better than expert when compared to standard ESD. They had less perforation, they had less complication, and they had a much faster dissection speed. So this is something that can enhance and change the actual way that we perform surgical endoscopy. But if it works so well, what we thought is that we can pursue the dream and go again back into the abdominal cavity. Why? Because we have precision now. So those rough movements that we were doing with the old platform, which didn't have any robotic support, are gone. And if you want to do surgery, you have to be precise. So probably this is going to be the next step. We are definitely not alone in the field. There are other surgical companies like the Flex system from Med Robotics that did a very similar platform, although here the only robotized part is the main scope. The arms are just mechanically activated. And it's a very interesting platform, a little bit shorter, 25 centimeters, so it suits only rectal and I would say lesions that are at the rectosigmoid junction. You cannot go farther. Maybe this is going to be a few future developments, has been used, of course, for ENT, and has been used also in patients comparing to the SI Da Vinci system, with pretty good results. And actually, the team that ran the study was particularly impressed by the ability to manipulate the platform and the flexibility of it, of course, compared very well to the Da Vinci, because you could access the lesion more easily than a rigid system. It goes without saying that this is an important feature of the device, which has a set of instruments that mimic those that you would use in surgery. So once again, this is for ENT, has been used for T0, T1, and 0 tumors in the rectum, and also as the video that you see there to remove a gist of the stromal tumor of the rectum, so for clinical use, especially in the United States. This is a platform that I'm very fond of. I tried it myself, and I have to say that it's very, very good competition. It comes from the Kai Center in Korea, and it's called a K-Flex system. It's very sturdy, extremely so, and is capable with these two arms to triangulate. Not in a striking way, I would say, but what is really interesting is how strong this platform is and how precise it is. It can lift up to 300 grams with one single arm. So it's something that could be very, very interesting, and this is something that I'm sure is going to be used clinically in the next few years. Columbus, I just have pictures. There are no videos available, but I did test this platform back this year, and it's a very, very interesting piece of innovation coming from the University of Texas, but it really comes from Korea, because all the engineers and the surgeon who developed it is a neurosurgeon of Korean origin. Very, very beautiful end effectors. I've never seen such beautiful instruments in any of the endoscopic platform that I've tested, and believe me, I tested them all. A little bit of problems with the triangulation, but this is something that I'm sure is going to be successful. Everybody knows the Auris Monarch platform that is currently used for lung cancer, but who knows? I believe that very, very soon we're going to see it also for different application, of course, ENT application, rectal application, but they're pushing very, very hard to go even lower and upper in the GI tract from both hands. What is the difference is precision. It really is a combined form of treatment, diagnostic while you're treating, artificial intelligence that allows you to precisely target the lesion, interpretation of the images. It really is the next level, and I'm sure that this is something where all the other platforms are going to go. Just to conclude, a very new system that was recently developed not for GI, but I'm sure that we could use some of their technology in the GI tract, since tubing is tubing everywhere. This is for the brain, and it is for removing blood cloth in the brain. It's a magnetically steerable hydrogel-coated robotic thread that has been developed at MIT. And if it can navigate through extremely thin structure, usually to make things bigger is very easy. And if you think that today we have different ways of tackling tumors, we don't have to remove them. We can burn them. We can use radiofrequency ablation, cryoablation, irreversible electroporation, other forms of energy. This is something that can really make a difference. Another one from the Chinese University of Hong Kong. I think this is a brilliant idea. Those are oscillating magnets that, thanks to magnetic fields, can acquire the configuration of a worm and can attack blood cloth. Once again, it's not the GI tract, is a vessel, but again, it's a tube. So I'm sure that in a near future, we could use the same technology in order to tackle cancer or any other lesion in the gut. And with that, I think I'm over my 10 minutes, and I wish to thank you very much.